So about biometry in pediatric cataracts, age and size, of course, does matter. The factors that influence the IOL power calculation are the age at which the surgery is done, knowing fully well that there is going to be a myopic shift. There are challenges in the axial length and keratometry measurements, the choice of the formula that you would ideally use in such cases, and of course the target refraction that you would prefer. Now, if you look at the growth of the eye at birth, the axial length is about 16.7 to 17 millimeters. At 1 year, there is a huge growth up to 20 to 21 millimeters. And after that, up to 15 years, there's a slow growth to 23.6 on an average. The mean K at birth is 51.2, but then it reduces over a period of time to 43.5. The lens power in the first year, it decreases by 10 diopters. And from the second to the 10th year, it decreases by about 3 to 4 diopters. So if you look at the axial length, there is a 3 to 4 millimeter of axial length elongation during the first year of life. And at the same time, the cornea and the crystalline lens are flattening. And so the refractive error, there is no refractive error in spite of all these changes happening in the first year normally, in any normal eye. But in an infantile cataract, what happens is the axial length elongation will continue, but the cornea flattens. But in aphakic children, there is no crystalline lens there. And that is why there is an increased myopic shift. Now, in aphakic eyes, the myopic shift can be corrected by reducing the power of the correcting contact lenses or the spectacles that you give postoperatively. In pseudophakic eyes, if the myopic shift is small, then it can be easily corrected with spectacles and contact lenses. But if there are larger myopic shifts over a period of time, of course, it will need an IOL exchange. Now, the challenge especially is in unilateral pseudophakia, where even if there is a large myopic shift, there is a significant anisometropia, which can lead to emblyopia. So this is another challenge that we face in all pediatric cataracts. So the question remains that the myopic shift is most possible when you are treating children below the age of 2, because the axial length is increasing drastically up to 1 year and from 1 to 2 years also. So what are the challenges? Now, one way of looking at it is up to the age of 2 years, you leave the child aphakic, and then around after the age of 2, you put a secondary IOL implant so that the child goes towards emetropia. But the challenge for those 2 years is that contact lens or hyperopic glasses are required to be worn, which is not easy. There is bound to be a lot of parental stress, compliance issues, and also the possibility of a dense amblyopia. So primary IOL implantation is a preferred method, and progressively nowadays people are going towards primary IOL implantation. But again, there are challenges. There is you have to do it under general anesthesia. It has to be in a supine position. The measurement of axial length, the applum, it is better to do an immersion technique, and your the pregar shell has to be perpendicular to the retina and not the cornea. Now, inaccurate axial length measurements are very possible, and for each millimeter of difference in an adult you will get 3 to 4 diopters, whereas in children it can range from 4 to 14 diopters. Keratometry, handheld keratometry is required. Our regular methods are not possible, and you have to take repeated readings and make sure that all the readings are in range. So an average of the readings can be taken. Now, the next challenge is the choice of the formula. Now, there is no specific formula for children. Adult formulas only have been used. Now, ideally, you would think that a Hofer Q is ideal for short axial length less than 22 millimeters, but it has been found in many studies that the mean prediction error is more in the Hoffer Q as compared to the other formulas, and there has been a wide range of studies that have been done. One of the Indian studies that have been done at Dr. Vasavda's place has shown that Holiday 2 and SRK-T show less of a mean prediction error as compared to the other formulas. Now, optical biometer and newer formulas, of course, for adult eyes are the gold standard today, but in children, it is not possible to do an optical biometry for the reasons that we just mentioned. Pediatric IOL calculators are nowadays available, wherein you feed in the data, it gives you the pseudophakic refraction of the child, and it will also predict the refractive change. But it was based on average eyes and refractive changes and did not entertain the outliners. So now the target postoperative refraction, it has been seen in a lot of studies, and one of the main studies done by NEAD that you calculate as age plus the residual refraction is equal to 7. So if you look at this, at the age of 1, you should have a target of postoperative refraction of +6. And similarly, 2 + 5, 3 + 4. So it goes to 7. The sum of the two will be 7. The other method is that you use a percentage formula. That is 1 to 2 years, the IOL formula minus 20%, 2 to 4 years, formula minus 15%. So, and this is how you keep on reducing the percentage as the age advances. Now, there has been a huge study that has been done, that is the infant aphakia treatment study, which was a randomized clinical trial, which was multicentric. It compared infants from 1 to 6 months of age, wherein the child was left aphakic and the correction was done with contact lenses. And the other group was a primary IOL implantation with the target post-op refraction as per the formula that I told you about. Now, up to 4 to 6 weeks, the target refraction was 8 diopters, and 6 weeks to 6 months, it was considered as 6 diopters. Another method of doing it is 2 to 4 years, the IOL powers should be the spheric, especially in the unilateral cataracts, the spherical equivalent of the fellow eye minus 1.25 diopters, and anything above 4 years, it should be the match the spherical equivalent of the fellow eye. Now, there have been many other ways and methods that have been tried. One of them was the pediatric polypseudophakia or the pediatric piggyback IOLs, which was a surgical innovation done by Wilson et al. And involves the in the bag placement of the IOL along with the second piggyback IOL. But honestly, doing this as a primary procedure and then removing that 20% later on, as it is the eyeball is small, putting a lens, and it has been seen even in all the studies earlier that in a primary IOL implantation, the complications like secondary glaucoma, all these things are more as compared to keeping the child aphakic. So this is again, I would say, questionable. Another point is the amblyopia. Hyperopia interferes with amblyopia treatment. So at a smaller age group, it is easier to keep the child more towards emmetropia, and giving amblyopia treatment is easier with lower errors. Children with small hyperopia or myopia accept the amblyopia treatment better, and it is advisable to calculate a less of an undercorrection. So now there are two schools of thought. Aphakia, up to 2 years, you keep the child aphakic and give contact lenses or aphakic corrections. Easier said than done. Compliance is a huge issue. But over a period of time, you will be able to give emmetropia at the right time, or go for the IOL implantation as a secondary procedure. Now, primary implantation with the less undercorrection going more towards emmetropia initially, and then going on, which avoids emblyopia, and then over a period of time, if need be, you can do an IOL exchange or any other refractive procedure. So the take home message would be target hyperopia to avoid myopic shifts, careful measurements to avoid errors in axial length and keratometry, IOL power calculation formulas, which have been derived from the adults, and more studies obviously are necessary. But whatever we have today, again, we are going more towards doing primary IOL implantations, doing closer to emmetropia in the smaller age group, and then tackling those children later on with contact lenses and with aphakic corrections, or even primary secondary IOL implantation being your procedure later on in age group, as compared to trying to fit contact lenses and aphakic correction in infants and babies. So this is the take home message.